Our next speaker is Dr. Thomas Hawke from McMaster, entitled Sex Differences in the Skeletal Muscles of Persons with Type 1 Diabetes.
Thank you very much for the invitation to speak here today. And unlike Yan, I'll only be presenting data that's recently been published, but based on the number of citations and Twitter likes, none of you have read it anyway, so it'll all be new to you. Let's see how we move this forward here. All right. There we go. And like many faculty members, you always want your trainees to be better than you are, smarter, more prolific, and that's all great and well and good, and I have the same philosophy, but then it becomes really difficult when those students leave and graduate, and then you're left to present their work and realize you don't really understand much of what they've done. So I will highlight the work that Cynthia Monaco, an outstanding PhD student, did in my lab, focused on the mitochondria of persons with type 1 diabetes. I'll highlight some other work that Ethan, Grace, and Lauren did while they were trainees in my lab as well. And a lot of this mitochondrial stuff wouldn't have been possible if it wasn't for a great collaborative network, including Chris Perry and his lab of Megan Hughes, Sophia Ramos, and Catherine Bellissimo. And of course, we're at McMaster University, and not a lot of muscle work gets done unless you're associated with Stu Phillips or Mark Tarnopolsky. So since I'm on the hospital side of the campus, Mark Tarnopolsky is our guy. So thank you to all of them, and hopefully I do this talk justice. So for those of you who don't know, type 1 diabetes is an autoimmune-mediated disease that attacks the pancreatic beta cells. Generally, the onset is in adolescence or childhood, and it results in a state of hypoinsulinemia and hyperglycemia. And the treatment for type 1 diabetes really hasn't changed in the last 100 years since Banting discovered insulin. That's exogenous insulin delivery, whether it be through multiple daily injections via a syringe, or if you're really lucky and can afford it, then you have an insulin pump. But the administration of insulin actually is kind of the easy part. The difficult part is actually managing the glycemia. And that's not just a daily thing, that's an hourly thing, and sometimes an even minute-by-minute factor. And there are so many factors that can affect glycemia that probably many of us who are not type 1 diabetic don't appreciate that when we go to eat lunch, or we go for a run, or we go to do things in our life that typically affect that. And as you can see here, this list of 42 things that affect blood glucose, many of these things have arrows that go up or down, and so depending on the time of the day or other covariates that are going on, it is actually really challenging to manage blood glucose, not to mention the fact that you need to be an expert in carbohydrate counting. And as I mentioned earlier, this is a disease that typically onsets during adolescence or childhood. And so it's not only a burden for the person with type 1 diabetes, but often for the caregiver as well, who needs to become an expert in all of these factors. And it's scary and it's daunting. And the way to manage or get at least a sense of the glycemic control is through constant glucose monitoring, and either through multiple finger pricks a day or through a continual or flash glucose monitor. You can get a sense in real time of what your blood glucose is. And I was fortunate enough to have Cynthia share with me some of her continual glucose monitoring. These are two 24-hour tracings, and so despite the fact that she's young, she's active, she has a CGM, and she knows a ton about diabetes, still had days largely spent in hyperglycemia and other days spent in hypoglycemia. So it doesn't matter how much you know, exogenous insulin therapy is not a cure for type 1 diabetes. It's a treatment that allows for survival. And it's these repeated bouts of dysglycemia and associated dyslipidemia and insulin resistance that invariably cause the complications, or are purported to be the mechanisms underlying the complications that reduce both the quality of life but also the quantity of life by as much as 15 years. So things like blindness, cardiovascular disease, kidney failure, nerve damage. And what was particularly interesting to my lab was this idea of frailty and physical disability, because many of the studies that are out there on persons with type 1 diabetes, these studies talking about frailty or physical disability, don't actually look at people with type 1 diabetes. It basically just says, do you have any form of diabetes, and here's the results. And so there wasn't really that many studies that were actually looking at the skeletal muscle and the frailty and the physical disability in persons specifically related to type 1 diabetes. And because my lab is a skeletal muscle lab, and that's what we look at, we were particularly interested in this idea of skeletal muscle, not only as a physical organ, but also as a metabolic organ. And I don't think I need to tell the audience here about the role of skeletal muscle in fatty acid and glucose metabolism and insulin sensitivity. But I think there's one important thing that often gets overlooked when we think about this, and that's the idea that if you don't have type 1 diabetes, insulin is secreted into the portal circulation and reaches the liver, and the liver gets the first pass, gets the first dibs at that insulin. So it's seeing insulin at 2 to 3 times higher than what you would typically see in the periphery, and it's got the first right to control everything. So it's the organ for glucose homeostasis. But in those with type 1 diabetes, you're injecting the insulin in the peripheral system. And therefore, you have to deliver it at the levels that the periphery is used to seeing, otherwise you induce hypoglycemia. And so the skeletal muscle now becomes the primary organ managing dysglycemia. And so we reasoned that this idea of impairments to the health of skeletal muscle could lead to deficits in the ability to manage glycemic control, but also lead to dyslipidemia and perpetuate insulin resistance, and that it may be that impairments to skeletal muscle that are happening early could actually promote the development and even the progression of these diabetic complications. And that's been the overriding theme of my lab for, well, since Mike Riddell and I went out for a run 19, 20 years ago, and he was having a hypoglycemic event, and I was collecting berries in the bushes to try to give him sugar. So how naive I was at the time when I knew so little. So at least he's here to laugh about it. But despite the importance of skeletal muscle in our metabolic control for the whole body, there's actually been very few studies that have looked at the skeletal muscle of persons with type 1 diabetes. And I highlight just a few of the very few studies that are out there, in particular these last couple of studies that use P31 MRS to look at ATP resynthesis in persons with type 1 diabetes. In particular, this study by Krieg Green saw decreases in ATP resynthesis in adolescence, and it was associated with the development of insulin resistance. But outside of these studies, nobody had really looked in detail about the ultrastructure of the mitochondria or high-resolution respirometry to really get a sense of where the deficits may lie. And this is really what led to the work of Cynthia in my lab. And she wanted to get right into the mitochondria because she knew that it wasn't just for ATP production, but played a whole host of other roles. But also that in persons who exhibit mitochondrial dysfunction, we do see these ideas of, or these impairments to skeletal muscle in terms of mass, reductions in strength, increased fatigability, not to mention impairments to metabolism and insulin sensitivity. And so the studies that I'll show you today were really centered around 2 cohorts. A young cohort of those with type 1 diabetes and age-matched, sex-matched non-diabetics, and an older cohort over the age of 30, up to I think our oldest was 72 in this study. And importantly, that this was a cohort, in both of these cohorts, we were looking at people who had uncomplicated diabetes. So they didn't have other complications that could create variability in the skeletal muscle health, right? If you can imagine, if they had cardiovascular disease or kidney failure, this could impact the health of skeletal muscle. So we appreciate the limitation that, is this the average type 1 diabetic who's 72 years old and doesn't have overt cardiovascular disease? Probably not, but it allows us to take out the variability that's associated with all of these other complications and say, does type 1 diabetes affect the health of skeletal muscle? So I've listed here as the young uncomplicated cohort, but it's really the same methodology for both cohorts. We got muscle biopsies. Some of it was used for permeabilized fiber bundles, in which we did high-resolution respirometry, and then other bits of the biopsies were taken for electron microscopy, Western blots, immunofluorescence, et cetera. And I won't spend a lot of time on the charts, but Cynthia did an outstanding job of matching for age, sex, BMI, physical activity, with the only significant difference being in their hemoglobin A1C or their overall management of the disease over at least the last 3 months. And when we looked at ADP-stimulated respiration, we saw an overall main effect at submaximal and maximal ADP concentrations in those with type 1 diabetes. And importantly, this deficit of about 20% that we saw in type 1 diabetes actually matched quite nicely with the P31 MRS studies that were done by Krieg Green and by Roden's group. So it made us feel pretty confident that at least in our hands, the cohort that we were looking at was matching the cohorts that had been seen previously, and it gave us a lot of comfort for what it was worth anyways. Now, there was no difference in complex 1 mediated respiration, but complex 2 respiration, again, was significantly decreased as a main effect, both at submaximal and maximal succinate concentrations. And while there was no differences in complex 1 mediated ROS production, there was a significant increase in complex 3 ROS production in those with type 1 diabetes. And when we looked at mitochondrial density using electron microscopy, both SS and IMF mitochondria were not different. And there was no difference when we used Western blotting using the OXPHOS cocktail. So no differences in mitochondrial density between the cohorts, suggesting to us that these deficits in mitochondrial function that we saw were not just an overall effect of a loss of mitochondria, which we had hypothesized was going to happen, but in fact, these deficits are intrinsic to the mitochondria. But as Cynthia was going through all of these electron microscopy images, she started to notice that in those with type 1 diabetes, she was seeing more of these swollen mitochondria. And so we recruited Christian Lamberts from the University of Bonn, who's an expert in electron tomography, to actually create these visual maps of mitochondrial cristae. And what we found was a significant increase in the disorganization of the intermyofibrillar cristae within those with type 1 diabetes compared to the matched control. So despite being physically active, being matched for physically active, exceeding the physical activity guidelines of 150 minutes per week, and without known diabetic complications and having fairly good glycemic control, those with type 1 diabetes in this study still exhibited intrinsic mitochondrial deficits that were not related to a loss of mitochondrial function. But as Cynthia was looking at this data, she was trying to understand what would be the correlate. There was variability in the data, of course, there always is, but was there something that related to the variability that we were seeing in the subjects? Could it be related to hemoglobin A1C or physical activity? And none of these things came out, but in fact, it was right at this time that Graham Holloway's group had published a paper, and he's going to speak next, maybe he'll talk about it, I don't know. But his group actually showed that there was differences between males and females in mitochondrial respiration in people that were otherwise healthy, without diabetes, et cetera. And so that got Cynthia thinking that maybe there was sexual dimorphism. And so she looked at her data, and sure enough, these things started to really tease out. We were underpowered in that study to look at that, so she went back and recruited even more subjects. And again, in collaboration with Chris Perry, we published this paper on sexual dimorphism in mitochondrial bioenergetics between those with type 1 diabetes, males and females. And so just to orient you here, because we were interested just in males and females with type 1 diabetes, everything is made relative to their matched control. So what we're looking at is the females here and the males here in blue. And in total mitochondrial content, there was no difference between cohorts. But in complex 2 respiration, where we saw that decrease in function in those with type 1 diabetes, it was virtually completely on the backs of males, that males had reduced function, whereas the variability was created because the females did not have that dysfunction that we saw in the males in complex 2. Pretty much everything else was similar across the board. But the other interesting thing to note here is that in complex 1 ROS production, we didn't see a main effect in when we combined the sexes, but it was interesting to note that actually females with the disease had reduced ROS production compared to the males, suggesting that maybe the females were reducing their flux through the cycle to try to reduce ROS production, but certainly that needs a lot more work to figure that out. And all of this led to Cynthia's final study that just looked at the older cohorts. We knew that there was deficits that were happening in the younger cohort, and we reasoned that after the age of 30, stuff was going to go downhill, and it was going to go downhill really fast. That's not really how it works out, even though you imagine big and better things. Did a great job at matching the cohorts and a really large collection of people in this study. And again, the only difference between the cohorts was with respect to hemoglobin A1C. Now, in contrast to the young adults, where there was no difference in mitochondrial density, in older adults, there is a loss of mitochondrial density in persons with type 1 diabetes. But the way that males and females get to this reduced mitochondrial density is actually different. That in females, there's a reduction in the size of IMF mitochondria, but not in the number. In contrast, males had a reduced number of mitochondria in the IMF mitochondria, but the size of each individual mitochondria as quantified by electron microscopy was not different. But collectively, there was a loss of mitochondrial density in both cohorts. So anything that we did with high-resolution respirometry, virtually all of that data was significantly less in those with type 1 diabetes because they had less mitochondria to begin with. But what we were really interested in was knowing whether each individual mitochondria had a dysfunction, not just that they had less. And it just completely blew our mind, but when we normalized our data to mitochondrial density, females with type 1 diabetes and their match controls were not different, but males actually had a higher intrinsic capacity for ADP-stimulated respiration. And when we looked at complex 1 and complex 2 mediated respiration, again, males with type 1 diabetes had higher respiration when we divide that by mitochondrial density. So remember, if we divide it by if we don't divide it by mitochondrial density, then there is an impairment, but each mitochondria that is present is functioning at equal or greater value. And we see that trend happening in females, but it didn't reach statistical significance. So we acknowledge that we're looking at a real small subpopulation of people with type 1 diabetes here, that they are sort of the cream of the crop, that they are very fit, that they're physically active, that they're managing their disease, they don't have other known diabetic complications, and that clearly doesn't represent the general population, and I think we can all appreciate that. But that they're losing mitochondria, but the ones that they have are functioning well. But clinically, does this really matter? While we all in the room would agree that mitochondria are important, the clinician really cares about, and obviously the patient as well, really cares. Is this going to affect function? And so this led to Ethan Dial's work where he graphed all of the quadriceps MVC data that we had from all of our subjects across the board. And we can see the solid lines are in blue are the males, and the solid lines in red are the females, and the dashed lines are those with type 1 diabetes. And what you notice is until about the age of 35 or 40, there's no difference in MVC function between those with type 1 diabetes and those without the disease. But after that age, there is a sharp decline in MVC in those with the disease. And if we draw sort of an arbitrary line at which point MVC gets so low that we develop frailty and physical disability, we can see that those with type 1 diabetes reach that physical disability marker sooner. And we recently just published a paper. This was an actual undergrad in my lab who did a phenomenal set of analysis on the Canadian longitudinal study for aging. And she pulled out all of these subjects within this large cohort that are being measured over time, so approximately 60 years of age, and they're being measured every 3 to 5 years. And what she found was that those with type 1 diabetes had significant reductions in grip strength. So this matched really nicely with our MVC data, but we also see it now with grip strength in a whole separate cohort of people. And 3 years follow-up, we still see that. The nice part is it doesn't appear in the same people to be getting any worse, but certainly the variability in grip strength starting to go down. And so we'll be really interested to follow this up year after year in these cohorts of people. So overall, what we can see here is in persons with type 1 diabetes, there is a loss of mitochondrial function. Whether you're 18 years of age or you're 72 years of age, how you get to that deficit in mitochondrial function? Well, when you're young, it's because you have a lot of really damaged mitochondria, a lower mitochondrial cristae density, and so what we refer to as an intrinsic mitochondrial deficit. With increasing age, and we don't understand the mechanisms yet, we seem to get rid of those damaged mitochondria, and we're left with just less mitochondria overall, but the ones that we have are functioning at equal or even better capacity. But there are functional deficits that are happening as we increase in age, and we'll be intrigued to find out whether there is a relationship between mitochondrial function and the overall function of the muscle with increasing age. And of course, I highlighted a number of sexually dimorphic effects of type 1 diabetes on the skeletal muscle, and as we develop adjuvant therapies for those with type 1 diabetes, we need to keep in mind that how we're creating these strategies have to be different between men and women if we're going to effectively do this. And we were fortunate enough just recently to be funded by CIHR, so if you have type 1 diabetes or you're interested in being involved in this study, let me know. It'll be a 16-week exercise training study and looking at detraining, so please reach out to me if you're interested. And thanks to the participants. Mike Riddell, we managed to coerce him to come and get a muscle biopsy. And our oldest subject, Harry Harrington, was just a hoot to talk to. So thanks to everybody, and thanks to the participants, and happy to take questions.
Thanks very much, Tom. Open for questions now. Yes, please.
Thanks, Tom. Robin Murphy, La Trobe University, Australia. Nice to meet you. Mitochondrial dynamics, are they playing a role in the sort of the fragmentation that you're seeing in the type 1 diabetics, or have you looked at it? And particularly with that new study, what do you think it might play?
Yeah, that's a great question. So we did some preliminary Western blots, mitofusion and fission proteins and things like that, and we didn't see any difference, but we'll be the first to admit that that's a really poor way to look at it. But so as an overall crude marker, we didn't see those differences, but I certainly think that transition from really damaged-looking mitochondria to really healthy-looking mitochondria with increasing age is something we need to understand more of. And we were really underpowered and didn't take the biopsies in the right way to really look at the things that we need to, but it's a great question. And we did look at rodent models using that same strategy, and we don't see the same phenotype in our rodent models, or it would have been a good idea to sort of tease that out in a rodent, but we don't see that.
Yeah, and sometimes it's just that balance, like the fission and the fusion can be happening in a nice, productive way to keep things healthy, and then you start to go down. So it'd be good to see a correlation.
Yeah, absolutely. You're absolutely right.
Great talk.
Thank you.
Thank you. Yes.
Hi, Gilles Guspillou. Thank you so much for your talk. It was great. Just a question. Have you tried to train these participants? Do they have any defects in mitochondrial biogenesis or?
That's an excellent question. So that's our study that we're starting in January. So we're going to do 16 weeks of training to see whether the mitochondrial adaptations are consistent across the board, and then also look at detraining, right? Say a COVID lockdown. Does detraining actually worsen in those with type 1 diabetes? It's a great question. We haven't done that, but that's what we're planning.
I'll come back for the next conference then.
Okay, perfect.
Great. Time for one more question.
I've never really thought about being a woman with type 1 before, but it
Sure you have.
did look like being a female with type 1 seemed to preserve that mitochondrial function, but I wonder why or how. Like, it's so fascinating.
Oh,
Have you have any thoughts about differences in fiber types or something that might be protective?
Yes, so we've looked at fiber types. There's not really a big fiber type difference between the two. We've measured a number of different factors between the two, and nothing startling is coming out. Cynthia hypothesized it's estrogen, and that estrogen's having a protective role, helping to act as an antioxidant, et cetera. And that's really just a question we've got to tease out a bit more. And we didn't do a very good job of that in the first set of studies, but it certainly would be interesting to do more of. But you're absolutely right. It seems that females with type 1 diabetes are more protected, both in their mitochondria, but also in ROS production, et cetera.
But we didn't see that difference in strength loss. Like the females lost strength too with age, like the men did, right?
Yes. Yeah. Great. Thanks.
Great, thanks very much.